record. There we go.
There you are. Well, hello again.
This is okay.
So how many people are showing up?
We had over 30 people registered. So there's people are starting to join the session now. So I can just do an introduction and then I'll give it to you to take over.
Okay.
Okay.
Are there breast cancer patients or involved?
I think we get the whole gamut here.
Yeah.
Women who are very interested, for sure.
Mm-hmm.
So I'd like to welcome everyone for joining us today. My name is Jillian Lashota, and I am the executive director of the I Rise Above Foundation. And I wanted to invite Dr. Mendez here today to speak to our community about something that I find really super important in my breast cancer journey in terms of healing and living well. So I'd like to do a little bit of an introduction of Dr. Mendez, and then I'll hand it over to her. So Dr. Mendez is a hematologist in Salem, Ohio, and is affiliated with Salem Region Medical Center and Cancer Care Oncology. She received her medical degree from University, I'm going to say it wrong. Dr. Mendez, how do you say it? University.
Kenya.
And has been in practice for over 20 years. She specializes in diseases of the blood, spleen, and lymph glands, treating such conditions as anemia, clotting disorders, sickle cell disease, hemophilia, leukemia, and lymphoma. And she's here to speak to us today about the COC protocol in breast cancer. How did I do for an introduction there, Dr. Mendez? Did I miss anything?
Well, also, I am a medical oncologist with 30 years experience in medical oncology, seeing all different kinds of solid tumors as well. Thank you. Thank you so much for having me. You guys are doing such an amazing job with this foundation. It's very encouraging, and I'm very proud to be able to speak to you today. Well, basically, 3 years ago, I thought I was retiring from my regular practice, and that only lasted like 3 months. And those 3 months, I couldn't stop just reading about the newest outcomes of different trials and different things. And also, one of the things that threw me into retiring at that moment was that I was frustrated with the standard of oncology. The hands of the standard oncologists are so tight in terms of having to follow the guidelines that, number one, they don't have the time to look outside those guidelines. And number two, if they go outside the guidelines, especially if they're working for a big institution, they get in trouble as well. And then within those 3 months, I found Care Oncology, and it was like heaven sent. I love working with them. Care Oncology has been actually around for 13 years. It started in the United Kingdom, and this was after extensive years of research, looking at numerous repurposed medications and numerous supplements that we're known to have some efficacy against the cancer cells. You know, the long list of supplements that some people are taking because this one does this and does that. Well, in their research, they found that there were 4 repurposed meds that were extremely potent in going through the wall of the cancer cell and attacking the mitochondria and killing the cell and depriving them of their fuel to survive and be able to multiply. And those are metformin, the lipophilic statins. We use atorvastatin because it's the most powerful one we found, and also mebendazole, the antiparasitic, and doxycycline. Then they went on to study those 4 combined. When they combined them, they were blown away because they could do so much more in terms of pathways, covering pathways that individually, if you added them, their functions of the 4, they could not achieve them individually, but together they could. Our scientific team tells us that they cover all the pathways when able to be used concomitantly. Another beautiful thing about them is that they travel the brain barrier very well. Important in many cancers that are notorious for, hello, okay. Somebody sending a message. Can you see it?
Yeah, you go ahead, and then at the end I'll read the questions.
Okay, very good. So in all those cancers that are notorious for their ability to travel to the brain, and one very important thing as well is that they attack the stem cells. We hear over and over again how the chemotherapies attack the cancer cell, but not the stem cells. And another thing that we have found is that when used in cases where there is an indication for standard therapy, let's say a patient that requires to go into chemotherapy, and then you add on the care oncology protocol, it's very important to use them concomitantly, because as the chemo is attacking those fast producing cells, then at the same time, the care oncology protocol drugs are creating a nicer environment for the chemo to be able to be more effective, and also at the same time, killing and attacking the stem cells as well. So it's good to use along with standard therapy, rather than waiting to finish the standard therapy to then get started. If somebody who's already finished with the standard therapy, it's okay, we can go ahead and start the protocol, but if you were able to start it from beginning, even better. Yeah.
That's a fascinating point, Dr. Mendez, that I didn't realize when the first time. I currently live with metastatic breast cancer. I'm in my 6th year. And after I was finished my treatments the first time around, when I was early stage breast cancer, I didn't have quite that understanding that the chemotherapy that I was on was specifically just targeted for the rapidly dividing cancer cells.
Mhm.
But then there's cancer cells in all different phases,
Right.
right? And so they don't, the targeted chemotherapy doesn't even address those, right? And so that's where the risk lies. Correct.
That's the risk lies. That's why we see so many recurrences, even shortly after finishing the chemo, because those were not touched. And it's important to remember that in the cancer journey, in the therapy of cancer in general. Yes. Then we have 6 physicians in the States. We practice. We have a base in the UK and then a base in the States. We serve all states of the country, also Canada, but we also have patients overseas too. So it's quite a wide range of patient population. When we started 13 years ago, our main focus was on glioblastoma, and that's all we saw. And we still have patients today after 13 years that are still on the protocol and doing well with glioblastoma with no evidence of disease, which is a disease that really has a very poor prognosis. We started then expanding to other malignancies, and breast cancer is, I think, our #1 now in terms of population of patients with such a wide range of ages. I saw somebody the other day that is only 28. My youngest in practice was 21. So when you list out, think that that little lump that a 21-year-old feels could be malignant, I'm sure that the physicians just turn them away. That's nothing. So, but it's very important to be proactive and to, do those self-exams regularly. And at the proper age, also start doing the mammograms as well.
Dr. Mendez, can you talk to us a little bit more about what each of the 4 drugs actually are? That's one of the questions in the chat was if you could just repeat those and list them and just talk about what they had been used for previously.
Oh, absolutely.
What repurposed means, I think that word,
Yeah,
or off-label or repurposed, what does that all mean?
yeah. Repurpose means that they were out in the market for something other than cancer, and then we are using them against cancer. So metformin, normally used in type 2 diabetics to block the spikes in blood sugar and also the big release in insulin after consuming a meal. It doesn't really bottom down the blood sugar. People think that, well, if I'm not diabetic, I'm going to take metformin, my blood sugar is going to be bottom down. That will not happen because you take it with a meal. And the cancer cell loves spikes in blood sugar and loves spikes in insulin. In that, one of the mechanisms where it fights the cancer is by not providing them with that nourishment. Then the statins, like I said, we like to use atorvastatin, which is Lipitor. However, there is two other lipophilic statins, the ones that are based in with fat. Those are the ones that are absorbed the best and that show the best efficacy in our studies. So the statins are normally used to control cholesterol. When we decide what statin to use or the dose to use, several things are important. One is their history of cholesterol levels. One thing we don't want, and I tend to monitor very closely, is the patient's cholesterol level. I don't want to make the cholesterol level too low. We need cholesterol for cognition, and in guys, it's very important for their testosterone production. So we monitor the cholesterol levels along with the protocol. The other thing is the hepatic or the liver function. Someone with a bad liver function, they might not do as well or might require a very low dose of the atorvastatin. Many patients come in thinking that more is better, when that is not the case. It's what is better for that particular person. So if somebody is on 10 milligrams of atorvastatin and somebody else is on 80, it not necessarily mean that the one person getting 80 milligrams is getting a better fight against the cancer. Then mebendazole is my favorite of the four. Why? Because it is so easy. It's once a day. I have never once had anybody complain about mebendazole bothering them. It is absorbed better with a little bit of fat in the stomach. And it is very, very powerful in traveling, trespassing the brain barrier. One thing I do bring into attention to our patients is that to be careful of not concomitantly taking other things that are necessarily processed by the liver or that could potentially increment the liver enzymes. Just like I mentioned that people think that the more things they throw into the package is better. I've seen patients lately coming that are already using fenbendazole and ivermectin, and then guess what? The liver enzymes are sky high. So then we have to wait for those enzymes to normalize before they start the atorvastatin and mebendazole. The mebendazole, if you look it up in terms of its potential side effects, it can also slightly decrease the white count. However, it's just like decimal points to the point that you don't even notice it. And it's extremely rare too. The doxycycline, it is an antibiotic, very effective against cancer. There is no long-term ill effects on using any of these drugs for years. Particularly the doxycycline, you probably have heard of people that take it for years for rosacea of the skin or acne. It is one that is mostly absorbed at the stomach level. Therefore, theoretically, it's not supposed to affect the microbiome. I still like my patients to take a probiotic when they're taking the doxycycline, just to be on the safe side. You have to watch for the fact that it makes the skin more sensitive to the sun. The last thing I want is for you guys to get blemishes on your skin from doxycycline. And also, it doesn't like to have any other medications at the same time with it in the stomach, like vitamins or minerals. So you have to space those out for a couple of hours. So those are the 4 and the ways to take them. Okay.
Okay. So what advice do you give to women in our audience listening right now who might be interested in learning more and how this protocol might apply to them, or how they could, start taking the medications? Can you tell us a little bit about that process?
Yes, yes. The process is they would email our case manager, and that information is on their website. And the case managers go over their case, take all their information. They do have guidelines, in terms of what would be a red alert in a situation when they have to contact me or another physician. Usually they call me to say, does this patient really qualify? What would make a patient not qualify? Things that will make a patient be kind of not qualifiable is somebody that is doing extremely poor, somebody that is home on hospice has exhausted everything and has progressed through everything. Because like I said at the beginning, our drugs are good, but they work slowly. So it's not like it's going to be a miracle thing at the end of life. So that would not be a good scenario. Someone that is hospitalized and going through a lot of difficulties, and we'd rather wait for them to get over that hump and then call us again. Okay. Someone that had a biopsy of and said it's cancer, but is refusing all medical evaluations and all potential treatments, that doesn't even want a CAT scan, doesn't want anything done. It doesn't make any sense, because if you don't get that standard therapy, like I said, to attack those fast multiplying cells, you can take all our medications and it's still going to progress to be, and then it doesn't make sense to promise them something that we're not going to be able to live on to. So that is the process. Once the case manager then gives them the appointment, and they have the choice of one of the 6 physicians that we have in the program. We have one that is a surgeon in GYN oncology, and we have a couple of radiation oncologists, and the other 3, including myself, we are medical oncologists, and I also have experience with hematology. So I did a lot of leukemias and lymphomas in my practice. They can choose, or they can let the case manager assign them to who they think would be a best fit. The first consult is an hour with the physician. The physician has by then reviewed their records. It's very important that we have the records, the pathology report, notes from the oncologist, all the radiographic reports, the list of their medications, the list of their allergies, because we have to put the whole picture together. Okay. Then by the time we sit down to see the patient, we have looked at all that, and we still have it in front of us to go back to if we have to. And then we go over everything again with the patient and make that the program that works best for them at that time.
We have a question from our audience from Lynn Murphy. She asked, for women taking hormone therapy for metastatic breast cancer instead of chemo, can the COC protocol be used in that case?
It can be used in that case, and metastatic breast cancer can be treated with hormone therapy alone. However, it's a case-by-case scenario. Is someone that did not qualify for chemo, or that refused chemo, or has already had several rounds of chemo and still progressing, is only doing the hormonal therapy. I've had in my practice patients on hormonal therapy for years and years with stage 4 disease. And so that would not be somebody that would decline. Yeah, that would be fine.
Right. Are there any other questions in the audience thus far? There must be questions, I'm sure.
So once you have the initial evaluation and consultation with one of our physicians, then our medications, you have two options. The 4 medications that I mentioned, the mebendazole is a compound medication, and it has to come from one of our compound pharmacies. We are contracted with 2 compound pharmacies that do a great job with our patients. The other 3 medications, you have the choice of either obtaining them also from our compound pharmacy and have all 4 medications mailed out to you, or if you give us your preferred pharmacy, commercial pharmacy information, we can submit it directly to them, those other 3, and then you can submit that to your insurance.
And how often do you have to do that?
Well,
how often do we see you?
Yes, the visits with the physician are every 3 months, face to face. However, we have what we call the support team, which is a group of nurses. We have 6 amazing nurses, extremely knowledgeable, not only on cancer, but also on nutrition. We have 2 of them that are also trained in cannabis, and they do consultations for cannabis with our patients. And once you have seen the physician, you have your medications. If you have a question about the medications, or you started to take them and you're concerned about a side effect, or if you're thinking of adding XYZ supplement that we didn't tell you to take, but you want to make sure it's not going to interact or counteract, then you can always email support@careoncology.com and discuss those things with them. You also can arrange a meeting with the nurse, and they'll give you half an hour, a whole hour, whether it is by phone or it is by Zoom, to meet with them and go over a variety of different topics, okay? They're really, really good about that. They will be your go-to people when you are trying to have an answer. If you want to run something by the physician, you still go that route, and the nurse will then forward that message, and the physician responds, and the nurse will get back to you with the physician's response.
I find the nurses to be so knowledgeable and really very helpful.
They are.
In particular, a few years ago, I started taking medical cannabis, and I really wasn't sure how to approach it.
Yeah.
And they were just so helpful to me in sorting it all out and knowing what the right dosage was and so forth. And then same with the supplements. So yeah, I can attest that they're really helpful. We have a couple questions. A couple from Lynn Murphy. She says, I am in Canada. I'm also Canadian. And she says, do we have to come to the clinic at any point, or is the care virtual, online, or both?
No, it's only virtual. Yes.
Okay. And then she follows up and she says, you mentioned that drugs can get processed in the liver. Are there any herbs or supplements that we should be aware of as well that can be processed through the liver?
Yeah. Well, the main ones would be the fenbendazole and ivermectin, ball-hydroxychloroquine, and there's a couple other ones too that are very notorious for processing through the liver. I forget the one right now, but anytime you're interested in a particular supplement, look it up, and it will tell you the hepatotoxicity level that it might have. And that one thing that you want to protect throughout your cancer therapy journey, number 1 is your liver. Number 2 is your kidneys. And with some therapies, you also have to be aware of what can happen to your heart, which is not that many of them that will affect the heart. But those would be more things given to you by the oncologist. But things you'll take on your own, protect your liver, protect your kidneys.
Okay, there's a question here. And I would say that once you start the protocol, you can always talk to the nurse about the supplements, right? Because they helped me.
Yes.
Okay, we have a question from Barbara Hewlett. Are there any studies on the effectiveness of this protocol? I'll say, Barbara, they were in the newsletter this past week. You can reference those. There were a bunch of them that are listed from Cancer Care Oncology. And her follow-up question is, will I keep my current oncologist?
Oh, definitely. We are not trying to take the place of your oncologist. And a lot of people will come to me and ask me, what do you think? And I'll tell you what I think. But, you know, if I disagree with your oncologist or so, it's something to discuss with the oncologist and something to expand your knowledge. But you still will keep your oncologist. Yes. What was the other question?
The studies of the effectiveness of this protocol. I think there's a whole bunch of them listed in on the web page.
Yes.
I included those in our newsletter for our wellness program this past week as well.
Yes. In the data, we keep collecting the data, and they keep telling me they're going to publish more in terms of breast and UIN cases soon. The thing that blew me away when I started was the publication on the GBM patients. That was amazing, because in my oncology history, you know, for a drug to be approved to be used in oncology, the FDA only has to see like an improvement in life expectancy of a couple of months, regardless of side effects. And our graph on survival for glioblastoma using both the standard and the Care Oncology protocol was amazingly super higher than the standard therapy alone. And what I see is that with my own patients in Care Oncology, they all do much better than my patients in my history in the regular practice with the standard therapy alone.
Okay. So I'm curious, why is it, Dr. Mendez, that, you know, sometimes with patients, they go to their oncologist and they say, I'm really interested in this protocol to be used in parallel to, you know, what I'm doing. And so many of us are met with opposition.
Oh, absolutely.
Why is that?
Absolutely. The oncologists, like I said at the beginning, have to follow the standard therapy to the T. Anytime they're going to put you in a new oncology regimen, any chemotherapy regimen, the first thing they have to do is submit it to your insurance. The insurance then is going to look at the National Cancer Care Network guidelines. The National Cancer Care Network dictates the pathways for the oncologist to follow and what the options for therapy are for that patient. And if they deviate from that, they say, no, we're not going to cover that treatment. And so they have to follow that. And especially when they're working for a big institution with a lot of trials, a lot of research, for a trial protocol, they are going to want their results to be due solely to their research drug. They don't want anything to affect it either positively or negatively. Some oncologists are starting to be receptive. I have had an oncology this week actually that was excited that their new patient was a Care Oncology patient. The first thing he said, oh, I love Care Oncology. But that is just very, very rare. Another reason too is that, you know, as an oncologist, and I've been like guilty of that myself, I want to know everything my patients are doing. And I want to know that they are not going to go out there and take something that's going to hurt them. So they are not as familiar with us, and they don't know how thoroughly we are in contact with you and how much we keep surveying all your blood work results. Our patients email us with all different MRIs and scans, any changes in their chemos, and the latest blood reports all the time, because we need to see that to follow our own guidelines of what dosages to change or what to put on hold or what to increment actually. So that's the problem with that.
Yeah, yeah.
Yeah, you kind of get an idea by how your oncologist reacts to different things, on how they will react if you tell them about this. But definitely with trials, they don't like anything else. Mm-hmm.
There's a question here that sort of follows up on this, and it says, how do you tell your current oncologist about these drugs, as they know what the main purpose of the drugs are for something else? So it's almost like, how do you educate your oncologist if they don't realize that these drugs can be used to block metabolic pathways of, you know, of cancer cells or stem cells? How do you go about that conversation?
Oh, I have patients do a variety of different things. I have patients that have given them the whole website information, or just pretty much just tell them, I'm doing this. I'm not asking for permission, but I just need to share with my physician that I'm doing this. You know, and sometimes they say, well, be careful with that one, that can do this or that, or blah, blah, blah. And they're like, I know, they're following on that. So I like to know as a doctor what everybody's taking. So I would feel bad if I was the oncologist and they didn't tell me.
Yeah. Yeah. And you know, it's, mine wasn't so receptive either, but, you know, I have to advocate for myself, and so
Right.
far so good.
Yeah.
Dr. Mendez, how often does a patient meet, if you became their oncologist through Cancer Care Oncology, how often would they meet with you? And does the frequency of the visits increase depending on, you know, if you're late stage cancer versus early stage?
The actual, what we call a follow-up or consultation every 3 months, the frequency doesn't necessarily change unless a patient would require to have a visit sooner for some reason. I have called many of my patients on the phone to check on them. If I see through the nurses that something is wrong, that they're doing poorly because of different reasons. So I email them, I call them at home. So they don't necessarily are totally out of contact for 90 days. It all depends on their particular situation.
Okay.
Yeah.
There's another question from Brandy Franson. If you need a prescription for some of these drugs, which you'll need a prescription for all of them, who would be responsible for prescribing them? And does Care Oncology work with the insurance companies, or is it independent cost?
When the medications, well, we prescribe the medications, okay? Some patients do have their own prescriber. Doesn't happen often, but some patients do. They have a family physician or someone that is willing to prescribe the other 3 meds. The compound one is difficult for them though. That's why we required it goes through our compound pharmacy. So we do prescribe them. If we submit them through your pharmacy, your commercial pharmacy, the atorvastatin, the metformin, the doxycycline, then it goes through your insurance automatically. If we submit those 3 through our compound pharmacy, then it's out of pocket. You still have the ability to get that expense from the pharmacy and submit it to your own insurance. However, I think it would be easier to just submit it directly to their own pharmacy from the beginning, you know. But you can do that. A lot of patients also ask for a super bill for the consultation, and they submit it to their insurance as well. Because everything adds up, so it's good to get that insurance to use.
Yeah, right. Yeah, cancer can be quite expensive.
Mhm.
And can you comment a little bit on the cost of these drugs if someone was to like outright pay for them and not have the ability to submit them for reimbursement? Are they super costly or are they affordable?
The average of the cost is like from 180 to low 200 a month for them. So I think that for the 4 medications, it's very close to copays for most people on 4 drugs like that. The most expensive one is the mebendazole because it is the compound medication. And then the cost of the mebendazole varies too, depending on the dose of the mebendazole.
So Lynn Murphy asked another question. Just to confirm, will a Canadian pharmacy fill a prescription from a doctor in the US?
We have an amazing nurse practitioner from Canada who
I've
has
received my drugs in Canada, so.
yeah, who has been heaven sent. And she deals with several pharmacies in Canada, and she takes care of making sure that your medications get to you.
That's a good question. Are there any more questions out there? No? Carla, I see your question there. I'll answer you offline. Okay, is there anything more, Dr. Mendez? Oh, Caitlin Glassick asks, what are the most common side effects people experience with this protocol?
Oh, well, that's a good question. Like I mentioned at the beginning of using the metformin, it takes several days for kind of your body to get used to it. And for a couple of days, you might feel like your stomach is upset. Uh, it's not much. You're not going to be throwing up or having diarrhea. It just doesn't feel right. But then your body gets used to it, and you go on to continue to take it and go on with the protocol. The doxycycline, if not taken specifically as recommended, which is full stomach, never empty stomach, and away from vitamins and minerals, you should do fine. If you lie down, you'll get reflux. If you take vitamins and minerals, you're gonna have a stomach ache. The mebendazole usually doesn't bother anybody. The statins in general, not just the atorvastatin, the statins are notorious for causing muscle pains, mainly large muscle groups like your thighs and your glutes, like you've been working out a real big workout, hard to come up the steps. It's not a pain that I want anybody to ignore because it doesn't get better, it only gets worse. You start experiencing any discomfort in your muscles once you start the statin, you stop it and you notify us, and they will guide you from there. If one statin has caused those side effects, then we can always change it to a different statin. Having it with one doesn't mean that you're going to have it with all the other ones, okay? And then 2, we monitor your liver enzymes very closely. I like to look at the kidney function as well because the creatinine is metabolized through the kidneys. I'm sorry, the metformin is metabolized through the kidneys, and we need to make sure that the kidneys are doing okay. That's pretty much it. Yeah.
Are there any more questions? Nothing's popping up quite. Did you have anything more to add, Dr. Mendez?
Well, what I have to add is I'm so proud of you. And I love my patients, and I have so many people in my patient population that have risen above all these problems and then shared with others and helped others. I saw an elderly patient yesterday that since she had the diagnosis, she determined she was going to do something for other people. Once a week, she gets donations of all kinds of dry food. She has a list of people that call her for, and they come and pick up groceries from her. You know, so it's all kind of different things. Um, and I encourage you guys to continue to do the great work that you do.
Oh, thank you so much. Well, this
You're
has been
welcome.
such a pleasure today, and it's been something that I believe has really impacted my, my health and wellness in dealing with metastatic breast cancer. I've been on this protocol for almost a year and a half now, so I'm very grateful for that. And I really wanted to just share the information with our community, and they can make the decision for themselves if they want to pursue it. Is something I highly recommend, but it's really everybody's choice on what works for them. So I encourage everyone to visit the Cancer Care Oncology website, read a bit more. There's under the section, if you Google Cancer Care Oncology and breast cancer, there's a page that comes up with a list of resources there, peer-reviewed articles and so forth. So I would encourage you to check that out. And is that updated regularly, Dr. Mendez?
Yes.
New articles that come out? Okay.
Yes. Mm-hmm.
And that's specific for breast cancer?
For a different diagnosis.
Okay, yeah. The one on the breast cancer page, though, I think it was related to breast cancer. So anyway.
Okay, very good.
Well,
Thank you so much, everybody.
Thank you, everyone.
Bye-bye.